Welcome to StudyNeuro, your home for high-yield neuroscience education and practical clinical pearls. If you're preparing for exams, clinical rounds, or just want to sharpen your diagnostic instincts, you're in the right place. In this session, we're tackling an important and often misunderstood topic, macroprolactinemia, and why a high prolactin level doesn't always mean true hyperprolactinemia or clinically significant disease. By the end of this lesson, you'll be able to clearly define macroprolactinemia and distinguish it from true bioactive hyperprolactinemia. We'll walk through the different prolactin isoforms and explain why only one of them is responsible for the classic symptoms you see in clinic. You'll understand how macroprolactinemia forms, why it accumulates in the bloodstream, and why it usually doesn't cause the typical features of prolactin excess. We'll also focus on the real-world clinical side, how to recognize when macroprolactinemia should be suspected, why symptoms alone can be misleading, and how to correctly interpret laboratory results. In particular, you'll learn how tests like polyethylene glycol precipitation help separate true hyperprolactinemia from benign laboratory findings. Most importantly, we'll connect this knowledge to patient care, showing how correct interpretation prevents unnecessary imaging, inappropriate treatment, and patient anxiety. If you find this helpful, join the StudyNeuro community on YouTube, Facebook, TikTok, Instagram, and X for more high-yield neuroscience content. Like, share, and subscribe so you don't miss future clinical deep dives. Macroprolactin is a high molecular weight form of prolactin that circulates in the blood as a complex rather than as free hormone. In most cases, it consists of monomeric prolactin bound to IgG autoantibodies, forming a large molecule, typically over 150 kilodaltons in size. Because of this large structure, macroprolactin has limited access to prolactin receptors in target tissues. As a result, its biological activity is markedly reduced, which explains why many patients with elevated prolactin levels due to macroprolactin have few or no symptoms at all. This form of prolactin is one of the most common reasons for incidental hyperprolactinemia discovered on routine blood testing, accounting for a substantial proportion of cases, often quoted in the range of about 15 to nearly 50%, depending on the population studied. The phenomenon of asymptomatic hyperprolactinemia associated with high molecular weight prolactin was first recognized in the 1980s, and the term macroprolactinemia was formally introduced in the mid-1980s. Since then, it has become an important concept in endocrine practice because recognizing it helps clinicians avoid unnecessary imaging, treatment, and patient anxiety. Prolactin circulates in the bloodstream in several different molecular forms, and these isoforms differ greatly in their biological activity and clinical relevance. The predominant form is monomeric prolactin, often called little prolactin. It has a molecular weight of about 23 kilodaltons, accounts for roughly 80 to 95% of circulating prolactin, and is the biologically active form responsible for the typical clinical features of hyperprolactinemia. In contrast, dimeric prolactin, sometimes referred to as big prolactin, has a higher molecular weight, around 45 to 60 kilodaltons, and circulates in much smaller amounts, usually less than 10% of total prolactin. Its biological activity is low, and it rarely contributes meaningfully to clinical symptoms. The largest form is macroprolactin, also known as big prolactin, with a molecular weight greater than 150 kilodaltons. Because of its size and reduced ability to interact with prolactin receptors, macroprolactin has very low biological activity. Its proportion in the circulation varies widely between individuals and populations. The key clinical takeaway is that only monomeric prolactin is responsible for the classical symptoms of hyperprolactinemia. This distinction is critical because total prolactin levels can be elevated due to macroprolactin without causing the expected clinical manifestations, leading to potential misdiagnosis if isoforms are not considered. Macroprolactin is formed when monomeric prolactin binds to IgG autoantibodies, creating a large prolactin immunoglobulin complex. Because of its high molecular weight, this complex remains largely confined to the bloodstream and has limited access to prolactin receptors in target tissues. As a result, despite elevated measured prolactin levels, the biological effect on organs such as the breast and gonads is minimal. In addition, macroprolactin is cleared more slowly from the circulation, which contributes to persistently elevated serum prolactin concentrations on laboratory testing. This explains why patients can have high prolactin values on blood tests, but few or no clinical manifestations. In most cases, individuals with macroprolactinemia are asymptomatic and do not develop the classic features of hyperprolactinemia, such as amenorrhea, galactorrhea, or infertility. Occasionally, partial dissociation of prolactin from the IgG complex may occur, allowing small amounts of biologically active monomeric prolactin to interact with receptors. In such cases, patients may develop mild or intermittent clinical symptoms, which can further complicate the distinction between macroprolactinemia and true hyperprolactinemia. Macroprolactinemia is most often clinically silent and is frequently discovered incidentally when prolactin is measured for unrelated reasons. Many patients have no symptoms at all, despite apparently elevated prolactin levels on laboratory testing. This asymptomatic presentation is a key clue that the elevated prolactin may not be biologically active. When symptoms do occur, they are usually mild and inconsistent. Some patients may report menstrual irregularities, subfertility or infertility, or occasional galactorrhea, but these features are not specific and can overlap with true hyperprolactinemia. Importantly, clinical symptoms alone cannot reliably distinguish macroprolactinemia from true hyperprolactinemia, making laboratory confirmation essential. Imaging findings also tend to differ. The prevalence of pituitary adenomas is lower in patients with macroprolactinemia compared with those who have true monomeric hyperprolactinemia. This reinforces the need to consider macroprolactinemia early in the evaluation of patients with elevated prolactin, particularly when clinical features are absent or mild.
Diagnosing macroprolactinemia can be tricky because standard prolactin immunoassays measure total prolactin and do not distinguish between biologically active monomeric prolactin and inactive macroprolactin. As a result, prolactin levels may appear falsely elevated, and this laboratory artifact can lead to misinterpretation, unnecessary imaging, inappropriate treatment, and avoidable patient anxiety. The reference method for identifying macroprolactin is gel filtration chromatography. This technique accurately separates prolactin isoforms and remains the gold standard for diagnosis. However, it is time-consuming, labor-intensive, and impractical for routine clinical use, which limits its availability in most clinical laboratories. In everyday practice, polyethylene glycol precipitation provides a simple, rapid, and low-cost screening approach. It is widely used and significantly cheaper than gel filtration chromatography, making it suitable for routine evaluation of unexplained hyperprolactinemia. After PEG treatment, the proportion of prolactin that remains in the supernatant reflects the amount of biologically active monomeric prolactin. A recovery of less than 40% strongly suggests macroprolactinemia. Values between 40 and 50% are indeterminate and should prompt confirmation testing when available, while values above 50% make macroprolactinemia unlikely. However, PEG precipitation has important limitations. Monomeric prolactin can co-precipitate with serum globulins, which may falsely lower the measured recovery. This can produce false positive results in patients with elevated globulin levels, such as those with IgG myeloma or polychromal hypergammaglobulinemia, seen in conditions like HIV infection. For this reason, PEG results should always be interpreted in the appropriate clinical context, and caution is required in patients with known hypergammaglobulinemia. When you see a raised prolactin level in someone who feels completely fine, that should already make you pause. If the elevation is only mild or moderate, there's no hypogonadism, and the MRI of the pituitary is normal, macroprolactinemia should be high on your differential. In real life, many of these cases are picked up by chance during routine blood tests done for unrelated reasons. The key is to recognize the mismatch between the lab result and the patient's clinical picture, and to question whether the prolactin being measured is actually the biologically active form. Understanding macroprolactinemia is clinically important because it helps us avoid unnecessary tests and treatments. By identifying cases where the elevated prolactin is mostly the inactive macro form, we can prevent unneeded MRI scans, unnecessary dopamine agonist therapy, and the anxiety that comes with repeated follow-ups. The focus should always be on the bioactive monomeric prolactin,
That's what truly drives symptoms and guides management, not just the total prolactin measured in the lab. To wrap up, macroprolactin is a high molecular weight prolactin IgG complex that's largely biologically inactive. Even if lab tests show elevated prolactin, most patients don't develop symptoms. It's fairly common, affecting up to 15 to 46% of people with hyperprolactinemia. Screening for macroprolactin, usually with the PEG precipitation test, is essential to confirm the biologically active monomeric prolactin. Doing so helps prevent unnecessary treatments, imaging, and follow-up, ensuring patients receive care that is appropriate and evidence-based. Recognizing macroprolactinemia allows clinicians to focus on the patients who truly need intervention, avoid misdiagnosis, and reduce patient anxiety. Remember, lab numbers are important, but context and clinical correlation are key. Join the StudyNeuro community for more high-yield neuroscience insights, tips, and clinical pearls, and stay tuned for the next session.